Nothing more, sir. Okay, really, I've listened in on different groups, so I know some really good stuff is here to be fed back, not only to Margaret, but to all of you, to Dr. Cook. So who would like to go first? Which group? Don't be shy. You're all going to be heard. Okay, you're on. Thank you. Peter. All right, if everyone could, I'm sorry, what's your first name again? Peter. Peter's going to represent his group. Feedback.
Okay, if I can have everyone's attention. We had, I think, 4 people from BC in our group, so not surprisingly, the care pathway that we came up with was the BC CCDP model, which has been in the works there for some time. One of Margaret's slides had a flowchart showing you that model, so this is sort of just an abbreviation of it, but it involves a multidisciplinary team, an assessment process that leads to, once all the information is gathered, a diagnosis and then care, and we added to that a need for continuing support. And after the patient goes through that process, there's a referral back to the family doctor, but that doesn't eliminate the need for some continuing support. On the question of what can we do in the short term, make use of the resources that are on the BC website. They're there and available for practitioners, patients throughout. And in Ontario, the recommendation was to expand the Environmental Health Center, which already is in effect a center of expertise, and it can grow and expand into the BC model. In terms of special groups and homebound, the recommendation was to make available an inpatient residential facility for patients who are homebound, and it may be short-term, it may be long-term, depending on the situation. Also respite for caregivers in rural areas. One option is to have experts travel to the rural areas to do assessments or care or whatever, or to establish daycare or day programs in the various centers. And virtual health, which is website again, I guess. And who needs to be involved? Doctors, patients, caregivers, pretty much everybody involved in the healthcare business, as well as social services or other government ministries or agencies that are impacted by this. Long-term disability insurers, providers, and service providers.
Peter, the other government services that I mentioned, I brought up this point, was the housing services. Because in BC, our patients are under tremendous strain with housing in Vancouver. If they are evicted, they are desperate. Anyone under housing insecurity or food insecurity cannot really look after themselves well and make any progress with their rehabilitation, recovery, and optimize their well-being. The stress is just overwhelming. So this is a social determinant of health situation that we run into. If that foundation is not there, that overwhelming stress makes it impossible for us to do our work.
Anyone else want to add anything?
Well said, Teresa.
Yes.
Peter and group, thank you very, very much.
Next group.
Tessie from the
So we're talking about a mature approach of having like a node and spoke system where a specialist clinic is sort of at the center of the design. So similar to the CCDP, where once people get diagnoses, they come there for specialist help, interprofessional help. But then following that, there is a connection to communities and connections to GPs, connections to home visits, connections to research. So it spans the province, it spans the country. Is there something I'm missing that you could add there, Rick?
Yeah, I just want to speak to that because although I helped set up the program in BC, I don't think it's the ideal model. I think the reason it's the model is because of funding and constraints put on us by other organizations. I am also a specialist in eating disorders, and we have a provincial eating disorder program that I think should be the model. And this is what Cassie is describing as the hub and spoke model. So we have a program where we have a center for excellence, and then we have regional programs all over the province that have an area of expertise. And then we liaise with the family physicians. So you can go back and forth between this model depending on acuity, how long you've had the condition, severity. On top of that, we have a parallel, not only outpatient, we have a parallel inpatient and residential program and home program. And so to me, that's a much more ideal model than what we've developed based on the constraints that we had in developing the CCDP.
Great, thank you. And then we just talked about a couple of others.
Sorry, can I just ask the question? Isn't that basically the CCDP with spokes?
No, because it has inpatient, has residential, has community, involves the GP more directly. Because often, so for instance, with the eating disorder program, we send the patient back to the GP, we liaise with the GP plan. If the patient gets a little too much with their hands, they can jump across the spectrum of the program, inpatient, outpatient, residential, community. So it's a much more fluid program than just the hub and spoke model with CCDP and other areas.
Right.
And we also talked about needs for this ideal approach to have obviously a virtual health connection, the research component. And then we talked about a couple of other needs that would be good to address. There were some really great ideas that came up in the group about figuring out or presenting to the government about how much money is wasted on unnecessary visits when people are trying to determine the diagnosis. And Rick was saying that there is ballparking from what he's heard from patients. People can take 6 months to 40 years, to find diagnoses and so many specialist appointments. So it'll be interesting to present that number to the government as to how much money is already being wasted and could we inject that into a program that will work. And we also talked about the HIV Navigator program out of UBC, I think, and some of the focuses there were on increasing the credibility of the disease, reducing the stigma. So those were two huge components that could be applied for what we're talking about here, as well as the community piece, the home visits for people who are too ill to leave their home. And groups as a connection piece, whether they're done virtually, so patients can have that support that they need, and whether that is also it's education based, but also the support there. We also talked about compassion fatigue challenge, and that working full time there's a lot of health professional burnout, so that needs to be considered as well. Is there anything else, team, that I'm missing?
Wonderful. Thank you so much. And our third presentation. You were just the unlucky one.
It's too late. All right. We felt that if we were going with patients going to a center of excellence, it would be important for residents or doctors to be trained through that center, so that they would have the information, and that they could go out into the community and spread the word, if you wish, and get other, GPs, etc., to do that. We also talked about perhaps a GP who was trained in that need to actually go and work with special groups of GPs in certain communities and help train them. So that was one of the way we looked at it. We believed in the importance of triage. We spoke of, a doctor triaging or a nurse practitioner triaging, but the importance of really being able, I think there was a push toward the GP in the sense of looking at, making sure the tests were being done. We talked about tests and making sure that we saw me as a spectrum to make sure that we had all the tests done, and that maybe the GPs wouldn't be able to necessarily interpret, for example, brain scans or things like that might be specialized. So we'd have to train people in being able to read these scans, and would it be better to do it through the center? Now, the problem we saw with respect to that was that, you've got one center for the province, then you're kind of limiting yourself to one resource. And we thought, as we know that in the regions, there are often the doctors will go through a call center, if you wish, that they're able to get doctors in the bigger centers to read their scans and interpret things. And that having rather than, if we can't train all the doctors quickly, maybe one way of doing that is to have people in a central location who are specialized, who can actually help, like a GP calls up and says, I've got this patient in my office presenting these symptoms, I don't know what to do with them, what would you recommend, what test should I do? And so that kind of thing would really be a useful thing. It's I think, more of a cost-efficient way of getting it off the ground really quickly. There were a lot of things that we said that weren't being covered that really should be. I mean, the BC model talked about, the fact that there are dietitians and counselors and nurse practitioners and naturopaths, I believe, at the center. There might be other people as well, but that maybe, and also the social worker is a really important person, because, for example, filling out forms and getting disability things and getting finances to be able to feed yourself, stuff like that, is really hard for people like us, so it would be really useful to have people who do that for us, and help the patients fill out the forms if necessary. It was said that the call should not disallow holistic types of tests. Yes.
I think what we were also saying is that in addition to that, rather than just management, which is I think that the CCDP is doing a really wonderful job of diagnosing people and setting them on a path to be able to cope with their illness and to have their families involved as well in understanding the illness. But I think to really be a centre of excellence, to be on the forefront of treatment and diagnostics. So for example, we have a SPECT scan at the Landscape Hospital, which could be used to do the kind of testing that somebody like Dr. Hyde is suggesting, along with a lot of blood work that doesn't get done, so that people can be seen if they've got any acute or chronic infections that can be treated. Anyway, along the lines of biomedical stuff, I think that's where it needs to be more advanced, and so the focus not just on management, but also on treatment that's cutting edge would be great. But I think that's where we'll hang at.
And the use of technology, using Skype for people who are profoundly ill and can't get to the doctor.
Yes.
Because right now you have a number of people who need help and they need funding from the government to live, and yet they can't get to the doctor, so they can't fill in the forms because the doctor needs to sign it. So there's a bit of a vicious circle there for people who can't get to the doctor and keep their appointments because they're just profoundly ill.
And I think the CCDP is addressing a pilot program right now, right? Which is really great, and that will address some of the issues. I mean, I think another thing we'll have to do for our community is consider mobile care. I mean, how long before we're ready to do that, I don't know. But I know it's really helped my daughter when we were able to have a doctor come to our house, and we had even a dental, an orthodontist came to the house and we believe that. But anyway, having people be able to come to the house is really, really found this important. So yes, that's a good point.
And at the bottom, we talked a little bit about what you were asking about the missing parts. So if you go back, there's some issues there about missing, about there were points raised about testing, like some really effective blood tests. A lot of doctors feel a bit hand-tied because I don't know if it's the college or who's causing that problem, but they don't want to do too much testing because it's too expensive. But it takes a lot of testing to diagnose and to make sure it's not other things. So I'm trying to think of the wording somebody gave me.
Exclusion testing.
Yeah.
Well, the other thing that's important is there's a lot of educational tests that get done, because you get passed on from one person to the next, they don't really have any control of it. And all the tests are redone, and also the fact that you're having to wait a long period of time before you go from one to the next, if the test is no longer valid, they're trying to get to the doctor. And yeah, so we talked about spec scans and tilt tables, so tests that seem to be accepted now as part of diagnosing the illness should perhaps be made more available in some way of
There's
getting
no
that.
tilt table in Ottawa, there's no spec scan in Ottawa. I had to travel far to have it done.
No.
Like those things.
Yeah, neither was I.
Where did you go?
Well, we went to Montreal first, and my son was injected with the wrong isotope, so then we had to go to
Yeah, we also talked about home-based support, which I think you touched on that, but it's really important. We think that there should be some home support. We're starting to hear about doctors doing home visits. I know that's the old approach, and I know a lot of doctors would resist, but a lot of patients miss appointments because they can't get there, fall between the cracks, and it might be a good approach to go that way, or at least through the use of Skype or something like that, be able to at least speak to the patient, keep in touch, find out what's going on with them, why are they not there, do they need an ambulance, etc. We also talked about, well, what's really missing, really, let's go on to that approach. We believe that there's really a need to train and educate on all aspects. We need to train doctors, we need to train the public, we need to train all professionals who are in healthcare. And we need to work with the associations, the colleges, to ensure that they support us and that they make sure that that they pass it on. I sold pharmaceuticals for a while, and I knew that if I spoke to the head doctor, the one that kind of, that all the other doctors looked up to, that if he said yes, then the others were going to prescribe. And so I think if we can actually get the college to agree, and we can perhaps, and the head of the medical school, it would go a long way. So maybe making that happen. We need to continue working on diagnostic tests and criteria to make sure that we're clear and that we're actually getting more things to support that it becomes clearer. It's not an either or. I think it needs to continue parallel to all of this. We need research funding. We talked a little bit about that, and I'll get back to that in a minute. We talked about and also a need to educate employers as to what these illnesses are and getting insurance companies on board, because of the fact that if we are missing time, perhaps there could be some work adaptation done as opposed to preventing us from working. Maybe we could get, more holiday time or, time off or share, co-share work or things like that.
Can I fast forward? Anti-stigma, can I talk about anti-stigma? That's kind of the big word down below. And I would like to see a campaign for anti-stigma. I would like there to be sort of a widespread, there be some sort of soundbite of a commercial or something that people can attach themselves to this and create some awareness on a profound level that doesn't even include going through the medical system. If there's anything I've learned through this this task force, this reading all the papers and sitting here, is I would like to see a widespread anti-stigma campaign, and that it goes to the employer, it goes to the medical, it goes to, say, the hotel who's using chemicals I can't deal with, it goes to restaurants, it goes
everywhere, right? It goes to family, boom. So anyways, that's my deal.
Right, so if you want to bring about change, the best way is through education and moving that kind of thing again. The other
What do you
thing,
have in mind for an autistic community?
I don't have
It
to
can
worry.
mean different things to different people.
One of the nice things about this task force is when I first read it, I thought, oh, the symptoms on it are too few and too little, right? Because there's so much more of the illness. The one thing that this task force does is it has kept it rather than the positive end on that, is that the positive end is that it's going to fit within, there's a statement of Annie on the short, right? And without going through every detail of it, that it just kind of like captures it, right? That's what
So you're talking about the IOM.
I'm talking about Ontario. I'm talking about starting with Ontario, but I'm talking about a nationwide commercial. Like I'm talking about a statement of health that society, the nation can say, oh, okay. Once you shine a light on something, it dispels lies and it creates truth, right? And that's what I like about the atmosphere.
yeah, I think both television and film have to be
Yes, thank you.
We also believe that, there should be more support for caregivers, like some of it already exists, patient groups are doing that, and support for patients, but perhaps there should be funding to help people that have better resources to ensure that happens, because it's sometimes even just technology to get people, to reach people or to put out newsletters or things like that. I mean, it can get expensive, and patients are actually, some of them are taking it out of their own pockets. I don't know what we meant by biobank.
To create, these are short-term goals, so starting on a biobank would be a good short-term goal. It would be doable, it doesn't require training doctors over the next few generations.
Can I just mention something? I spoke to a woman today that she was mentioning to me that she spent every penny of her money on her daughter. She visited to Germany, she went to Switzerland, she did in California. She spent everything. She's scared to find out what can she do. She's not like, she said, I'm an older woman, I'm almost done my career, like, I just, what do you do? So I'm just worrying that if there is a problem with the whole idea of funding, like where people can go to get funding.
Yeah. And,
And how?
and if this illness is a treatment, we're losing a lot of good power up there. A lot of people can do a lot of things, but now disappearing. We also need a national registry of the numbers. We don't really know what the real numbers of this illness are. It would be really good to be able to say, clearly how many people have this illness, not just the ones who are presently diagnosed. I promise I'm going to end soon. This is the last page. Well, we said who needs to be involved. Well, this is federal government, but also the provincial government and health authorities. Those are pretty obvious, I think. But the people who perhaps aren't so much involved are for example, the other professionals. Like, I don't think it's taught in nursing schools. I don't think it's taught to physiotherapists. I see a physiotherapist who said, wow, it'd be great. I didn't even know about this illness. I should have to see Unmet, and she saw the movie, and I said, wow, that really opened up a lot of things for her. Why isn't that movie shown everywhere in schools? I think if that kind of thing could be shown everywhere or, publicly, and it would be a very good thing. I talked about all of this. I think that's it. Yeah. Wow, wow, wow. Right up. Oops.
Yeah, thank you very much, Ryan. That's really valuable input. I know I saw Dean writing every word. So we'll certainly go back to the task force, and Maureen is going to make sure that we do it right. Yeah. I know I can count on Maureen for that.
Okay. Short term, I will be typing those up. They will be sent out to everybody who Margaret has the email address of, along with the report that we gave to Dr. Colson by Dean. So if you don't think Margaret has your email address, give it to her, and you'll be the recipient of these typed up and a report. Okay. The last thing, which we had originally allocated about 20 minutes for, and it's now 5 after 5, so we're 5 minutes finished, was to capture what are the big next steps, and I really stress big next steps. You know, it isn't Marco type flip charts. So maybe in the interest of time, and a lot of it was here, but if I were to ask you to say, there's only one thing we need to do, let me hear from you. What is the next big thing we have to do? Yes.
I think it's educating doctors. Because if you can't get your first step in the door, the rest of it will fall into place.
What do they,
10 or 11
now, what do they need to know? Because I mean, we did contract with Ipsos to do a poll, and I think the frustration that I hear from patients is shared by many primary care physicians.
You need to educate patients too.
This is what they need to know.
They don't have.
What is that that you're holding up?
It's the diagnostic criteria, the international consensus.
They don't know what the sessions are.
They don't know how to diagnose it, they don't know how to manage it, and that's best case scenario. Many patients, and you get this, Sherry, and you get it too, Gloria, this in BC, and I'm sure it's throughout the country, they get laughed out of doctor's offices, they get ridiculed. If the doctor decides you've got chronic fatigue syndrome, that's it, you don't need anything else, you're done. Out the door, and don't waste my time. I mean, it is horrendous.
It's horrible.
You're lucky if you have a doctor who can diagnose you within 2 years. I mean, it's like, really? That's amazing. So,
I'd like to see a specific billing code, so that everyone can say.
yes.
That's a huge.
Diagnostic code, billing code. But we have
Yeah,
neither of those in
that's not
BC. In Ontario, it's a billing code, right?
Well, I think there's questions about what that billing code covers, and I think that
But you have one. I mean, we haven't even got one. Which most of the country, I think the rest of the country, no other province has it, right?
And if we promoted, I'm a little bit different than Gloria, I would promote the 2014 IACFS NE primer because it's more recent. And that's why I would argue against a new definition because it just makes people even more confused. We've got a document, it's had international input, that even the CDC is recognizing it. I think we should go with it. The document is there. All we have to do is hand it to them with some authority to say, this is a thing, read this.
I hope that will be the consensus out of the expert group.
Because I think because the symptoms are moving even on a single patient, it's tough to like nail it down. So I think any conversation is just going to change.
Can I just clarify this 2014, and I'll get the right terminology? Was that the document that you're suggesting as part of the education?
She held up, I think,
There's different ones that people are going to hold up, right? So
So I captured the diagnostic criteria that you referred to, and this is a second thing.
2014 is an update of what Gloria held
Thank you.
up. And I'm just saying it's more recent, so
Okay.
and it's international, so for sake of this one.
No.
The IACFS NE primer is what
IACFS NE primer.
Now, Margaret Powler has an interesting way of looking at these diagnostic criteria, so that the C one from the IOM is seen as an entry point because it's simple and easy. And the doctors who don't want to put the time and effort into reading any document that doesn't have ads, that would be focusing on free trips to Bermuda to learn about socks and feet. Those doctors can read that, and then they can process a patient to the point that they can get some amount of help. But to truly diagnose it, then use one of these more in-depth ones. So I think, Margaret, if I got you correct on that, that's what you were suggesting, right? I mean, that sounded like a good.
The one I'm saying that I'm not sure, I think that the IOM criteria do need to be tested.
Yes, they need to be validated.
Validated, yeah.
Okay. I
And
have
I
a hand
can,
up.
I would throw in the, I've got two hands, so if I can capture that one.
Yeah.
And then,
I don't know if it's quite related, but I think that the doctors need to feel comfortable to refer to alternative medicine. And there should be funding made available for those, because if patients have to pay for that outside of their pocket, again, they're out of a job. So if there could be a way for those costs to be covered as well, would be very useful.
The pediatric primary just come out. It could be definitely worthwhile for that to be distributed to all the pediatricians. Pediatricians generally do not check blood pressure or heart rate, and it's not a big deal really to check that on an examination. They don't even have to do the 10-minute test. If they just check somebody sitting down and standing up, they can catch a lot of people very easily with the POTS. And also a list by specialty. The specialist all have to know. When you go to a GI, you go to a dermatologist, you go to a pulmonary, each different specialist, you go to ENT, they can catch a lot of the symptoms of hip. Just have a list by specialty, that they're familiar with it. Never mind complicated diagnosis, just some of the main symptoms. They could pick up a lot of patients. They need someone to refer to a specialist. That has to follow up after. But if they know the main symptoms by each specialty, any conferences they go to, they could be brought up. They should have at least a list of that. Family physician refresher courses they have, each different specialty is presenting. They can have a list of that also. They can include the CCC, the primer, the pediatric, any of them. They have it all digital right now. They can all be included. But a main checklist with each different body part they can have, and they can see it really easily.
okay, thank you.
Along the lines of the alternative medicine, sort of educating the doctors perhaps on which ones seem to be working better for patients with ME. Because, you know, there's a whole slew of things out there. You know, why do companies feel that this is better than something else? And, you know, what might work? Some doctors do not believe in it at all, but it seems when nothing else works, that's the only thing you have left, right?
Can I ask you that? With the alternatives, there are so many different things and people respond uniquely. So it's very hard for a doctor to say, you will respond to such and such a modality and you will respond to another one. It's often a patient who has explored those modalities and they know and they tell the doctor, oh, I did really well with Reiki or acupuncture. My special interest is acupuncture, and in very brief language, it really hits the parasympathetic system and turns the switch from the sympathetic fight or flight to parasympathetic. And there are pretty rarely any drugs that can actually help you with that homeostasis. So a lot of the alternatives are working on the same system. It helps your parasympathetic tone up, so you feel less stressed. Your brain has a better chance of equilibrating, homeostasis takes hold, your visceral regulation improves. So that's why the so-called alternatives help. They're helping through that neurological pathway. And it's so individual because we're all different in our parasympathetic system.
But it's the same with pharmacology. Pharmacology, everybody responds differently to pharmacology, so
That's true.
you know, wouldn't you be able to teach it the same way? Somebody will prescribe one medication for somebody.
I agree
the
with you,
same
but it's a
medication
case
for
of
somebody.
exploring and finding what works. And when the patient finds one thing that works, wonderful. The downside of patients getting involved in too many is that they spend energy going around too many people. So they have to narrow it down, find a modality that works well for them, and it will help them.
So I'm going to hold because I'm on the verge of doing a wrap-up. We have two more people that want to contribute. You've got the time for that plus a 5-minute wrap-up? Everybody okay? All right, then.
I'll be super quick. What I was going to say is I'm just hearing about this place in Vancouver and the other one in Nova Scotia. I'm thinking I need to take my son there. We don't have any treatments. We've been diagnosed and that's all we have. But why can't those centers of excellence, rather than holding on to, not to suggest that you're holding on to it, but why can't there be interest or sharing or something so that people like me who live in Ottawa don't have to fly my son who can't fly very well to Vancouver, but just have something where we know, to your point, maybe acupuncture might work. Try this, because I go on these Facebook sites and I'm so overwhelmed, I just want to cry because I don't know what to try, what not to try, what's good, what isn't, but just a concept of things that we can try. And I understand to your point that nothing works for everybody, but it's so big right now, I don't know where to begin or end. So if there are approaches that are being really well utilized in Vancouver and Nova Scotia, I would welcome my doctor to be aware of that, you know, because I don't know, I'm contemplating going to California, I don't know what to do.
Thank you.
I think that fits into what you said earlier about collaborations between physicians in different places, and the centers of excellence hopefully will have communication with physicians elsewhere. But I want to speak to the number one big thing as educating doctors, as everybody says. And I've been on the trying to do that for many years. And the medical school curriculum is really fixed in a way because everybody wants to get something new on it. And it's very, very full, okay? But we're not teaching anything broadly new. We should insert environmental health into the medical school curriculum as it is now. And I think the big thing would be to have a recommendation from the Minister of Health of provinces, the National Minister of Health, to do that. That's it. Here, here.
Whoa. Margaret, I'm going to have to cut this off, but let me do the close and then let me invite everyone to keep talking amongst yourselves as long as you can stay. But, you know, people have flights and so forth, so I'm really sorry. It's a horrible job. I got a lot of thank yous to give today. First of all, I want to thank the whole audience because you have been so engaged. I guess everyone's been desperate to speak up, and that was evident, but you've been so engaged that, you know, Dr. Popes and Fidene had stayed later than originally. So, thank you. I want to thank Lydia and Margaret because about 2 months ago, thanks to Larry Dahl, I was introduced to them, and they were at the point where they had identified the need to have a patient and patient caregiver event. Like, whoa, isn't that a novel idea? Sort of, right. And so a huge thanks to them for championing this event. A huge thanks to Margaret, who I've worked with over the past 2 months. And when, you know, a facilitator says, oh, Margaret, could you put together, you know, your slides, or Margaret, can you put together the letter that goes out to everybody or whatever, that's all out of her personal time, just like everybody's contributed. So a huge thank you to Margaret. I'd like to thank my brother-in-law. Who is actually, you know, he does videography for a living, but I said, there's no money, we need you. I am here.
It was my pleasure.
So thank you, Serge.
Thank you.
Thank Larry, who's been running around all day doing all kinds of things to help me, so really, really appreciate it. And I want to thank everybody here, and Marvin, you've got to thank everybody who contributed the 24 plus still coming inputs to Dr. Pope's report. And thank you. Thank you. Just thank you, thank you, thank you. I think it's been a great day. So over to
Well, first of all, I would like to add Margaret, thank you to Margaret, who has done such a good job. For all of you who organize this. I mean, she'd get on the phone and say, okay, this is what we're doing next, and I sit there and do it. Okay, I'd like to thank you all for coming. I think we've covered a lot of territory today. The Ontario Task Force, all the feedback we got said that this is a very valuable document. not a perfect one, but a very valuable one for moving forward. And we've also gone through the exercise of looking at the diagnostic and treatment protocols, which are very difficult issues. And as I say, will not necessarily be resolved easily, but we have to find ways of working in areas of uncertainty. And the care pathways, now the Arthritis Alliance of Canada spent years working on them, or at least a year or two. We're not going to solve it in 25 minutes, but we've begun the discussion so we know what to do and know what the issues are. We have another day or day and a half of the conference. We're going to have a patient day tomorrow with some speakers in there. Some of those speakers are very knowledgeable on some of these topics. I think some of the discussions from this meeting are going to come back tomorrow. They're going to come back next week and week after, but we're going to work together to solve them and to get better care for people in Canada. Right? Right.